Thank you for my introduction and thank you the committee for inviting me today. I have no conflict of interest to declare today. First of all, I will talk about escalation and the escalation in septic shock treatment in children. Since I have only 20 minutes to talk, so I just going to talk about the first two items, about the fluid management and later on the vasoactive drug management on pediatric septic shock. First of all, if we think about the fluid management in pediatric septic shock, the first question might be, which fluid that should we give to our patients? So if we see in this study that is compared with the balanced solution versus the normal saline group, and the outcome that we are concerned is about AKI, we will see if in the patient receive the plasmolite has the incidence of the AKI lower than the saline group, particularly in a severe AKI which require RRT. The patient who receive plasmolite has the incidence of the RRT requirement only 9% versus 16% in the normal saline group. So the first question, do we still give the normal saline in our pediatric septic shock anymore if we do not want our patient to have a severe AKI or need a preventable RRT requirement? We should use the balanced solution rather than saline. And the latest guideline recommend us to use the balanced solution rather than saline in terms of fluid resuscitation of pediatric septic shock, SMS adult septic shock guideline. And the next question, I will move to the pattern that we give to our patient in terms of fluid resuscitation. We divide phase of the resuscitation into the two phases. The first is the early phase, and we divide at the early phase to two groups, that is early adequate and early conservative. You will see in the patient with the received amount of fluid adequately in the early phase has a very lower mortality rate compared to the inadequate fluid resuscitation in the early phase or resuscitation phase. After that, if we move to the later phase, let's say after a few hours on the first hour, and we divide it into two groups. The first is the later with the conservative fluid treatment, and we have the later with liberal strategy. The first group that has a lower mortality is you should give the fluid in the early phase adequately, and after that you should avoid fluid overload in the later phase at all. And that is concept of ROSE. If I talk of multiple slides today, and you might cannot remember all of my slides today, just keep in mind that this is a keyword of our talk today. The first one is from adult strategy, which is called as a ROSE concept. The ROSE stands for the resuscitation phase, which is in the first few hours, and after that, the patient moves to the optimization and stabilization phase. And after the second day, that is the move to the phase that we call evacuation phase or the resuscitation phase. But in adult, we have 4 phases to separate the shock state or the treatment strategy according to the phase of the patient. And it is a character of the phase up to the ROSE strategy. I will focus first on the resuscitation phase first. The resuscitation phase is in the first hour or the several minutes after the patient becomes a septic shock. We give adequate fluid resuscitation in this period, and we aim that the fluid balance should be positive in this phase. And after that, since after the first few hours to the second day, we try to keep the neutral fluid balance on this phase. And if the patient on the evacuation phase, since after the second days, we should aim to negative fluid balance on this stage to remove the fluid overload of the patient. But this year, in the pediatric concept, we changed to the rose to the red, and we couple the middle phase to equilibrium phase. The first phase is the same as adult, which is the resuscitation phase, but the mid phase is we call as equilibrium phase, which is a component of optimization and stabilization into the long-term equilibrium phase. So it starts from the first few hours to the second day, and we might keep the IO at the neutral balance at the mid phase or at the equilibrium phase. And after the second day, we move the patient to the escalation phase, that we aim the negative fluid balance in this phase. So I will start in detail with the first phase first. In the first phase, the objective of us is the restored intravascular volume, which is markedly depleted in the first few hours to the euvolemic stage. Since the hypovolemia and hypervolemia are associated with the first outcome, so we try to restore to the euvolemic as soon as possible. And how much amount in the first hour that we should give to our patients? What is the lower margin that our patient should receive in the first hour? If you see this study, the patient that received the fluid higher than 40 ml per kilo on the first hour is associated with the best outcome. If you see the patient that received the fluid lesser than 40 or even lesser than 20 ml per kilo on the first hour, the mortality rate is highest. And what is about the upper margin? We look back to the classic study here. If we took the pediatric septic shock and we give the resuscitation fluid up to 60 ml per kilo on the first hour, and then we perform the PA catheter inside the PA, and we measure the wedge pressure to represent the preload of the left atrium. All of the septic shock patients that already received 60 ml per kilo has adequate preload of left atrium. So the lower margin should be 40. The upper margin should not exceed 60 ml per kilo in the first hour. So that is according to the lesson guideline. The first hour, we should give the fluid to our patient about around 40 to 60 ml per kilo on the first hour. And I just wanted to remind you about the vicious cycle of fluid resuscitation. Every time that we give the fluid to our patient, it doesn't contain only in the intravascular, it's also leak into the interstitial fluid and cause the edema of internal organ, particularly in the encapsulated organ, such as the kidney. So if we have an acute kidney injury, the urine output is going down, and when we see that our patient has inadequate urine output, some doctor might give another fluid administration to the patient. So the vicious cycle might repeat it again and again. So how to prevent the fluid overload in our patient? So if we concern about the fluid accumulation syndrome, the fluid accumulation syndrome has detrimental effect to almost all organs such as kidney, lung, heart, brain, and so on. So how can we prevent fluid accumulation syndrome in our patient? So after the first hour, if the patient became hypertensive and we think about to give another fluid in our patient after the first hour, we should have a tool to predict that our patient might have benefit from the another fluid resuscitation rather than get the harmful effect from the fluid overload. So we have the tool that predict fluid responsiveness. And we can divide that tool into the right side heart and the left side heart. If we use the dynamic index that's On the left side edge, a store volume variation after the passive racing test, or respiratory variation on aortic flow velocity, or store volume variation between the respiratory cycle. The area under the curve in the left side variable index is usually higher than the right side. The right side shown as an example as is IVC descendability index. But the dynamic index, even the right side, is much better than the static index such as CVP. If we look at this picture, we cannot rely on CVP in terms of fluid responsiveness anymore. And after the first phase, we just give the 40 to 60 ml per kilo to our patient, and the patient after the first few hours, they move to the equilibrium phase. What is the main objective in this phase is to prevent, to avoid fluid creep in this phase of patient. And what is the fluid creep? It's like something creep in our body and no one's noticed it. The fluid creep is the fluid that usually higher than maintenance fluid level that is creep into our patient. And it's come from, what they come from? They come from the medication, antibiotic, sedative agent, or also nutrition, either enteral or parenteral routes. So how common about the fluid creep in our patients? And what is the importance of fluid creep in our patient? If we look at this study, after day 3, in the sepsis with a positive fluid balance, you see the blue line right over here, usually has, in a non-survivor group, has a positive fluid balance in after day 2 after that. But if you keep the fluid balance to neutrally or slightly negative in the day 3 and so on, the patient usually survive if you successfully keep the IO balance or slightly negative after the 3rd day of the illness. And what's about the mortality between the no fluid overload and significant fluid overload in our patients? You keep the patient has 20% of fluid overload, the mortality is going up to 8%. But if you can't avoid fluid overload in our patient, the mortality was going down from 8 to only 1.6%. And how common? In the fluid overload up to 20%, at the day 3, usually has intake 90% higher than maintenance fluid level. So it's very common on the 3rd day if we do not strict to the intake, that is, we have to lower the fluid intake not more than maintenance fluid level. Since the IO positive is usually caused by decreased urine output, but we do not strict the intake not more than the maintenance fluid anymore, maintenance level anymore. So if we can strict to the maintenance fluid level on day 3, we can use the fluid overload up to 8 ml per kilo on the 3rd day. So it's easy if you stick to the intake that you order, that you prescribe to our. If you stick to the intake that you order, that you prescribe to our patient, not higher than maintenance level on the day 3. So if we make the patient still survive into the de-escalation phase, usually after than the 2nd day, the main objective in this phase that you should get a negative balance on this phase, either from spontaneous urination of our patient, or you can active intervention by something like furosemide, bolus or furosemide infusion. You may perform CRRT if indicated, or sometimes we think about the fluid accumulation in the interstitial space, right? you have to move the fluid from the interstitial space to intravascular phase first. So sometimes you have to use hyperoncotic albumin to affiliate the movement of the fluids. You might use the 20 or 25% human albumin accompanied with furosemide infusion to shift the fluid from the interstitial space, come to intravascular and turn to the urine output of our patients. And what is the importance of negative fluid balance in the de-escalation phase? If we see, if on the third day, if we get the negative fluid balance on day 3, either spontaneously or with some intervention like diuretic, CRRT, or hyperoncotic albumin with furosemide infusion, that is cause the mortality rate decrease up to 70 to 90%. So it's a main goal in the de-escalation phase of the fluid management in our septic shock patients. So I want you to get the take-home message about fluid management in our patient. First of all, isotonic balance solution is the first the fluid of choice in pediatric septic shock, and you can bolus 10 to 20 ml per kilo in each bolus, up to 40 to 60 ml per kilo in the first hour. After that, if the patient becomes hypotensive, you should give the subsequent bolus fluid resuscitation with cautious and give only that you have tools that to predict that our patient has a fluid responsiveness only. And in the equilibrium phase, keep in mind to avoid fluid creep in equilibrium phase, and you should stick to the intake not higher than maintenance fluid level on this phase. And in the de-escalation phase of fluid management, you aim to the negative fluid balance on this phase, whether it came spontaneously or you have to intervention something, you give the diuretics, CRRT, or hyperoncotic albumin. I have a few minutes about the vasoactive duct management. I just talk about the first thing, that when we should consider to give our patient with the vasoactive drug. If we see in the latest guideline, the guideline told us that we should give the vasoactive drug after 40 to 60 ml per kilo of fluid resuscitation, and our patients still in persistent shock. But on the study published in 2021, they divide the septic shock patient into the 3 groups, and the first one give the vasoactive drug after the first bolus 10-20 ml per kilo, and the second group at the second bolus, and the third group at the third bolus, or 60 ml per kilo. And what the result of the study told us, in the first group, it means that you give the vasoactive drug after the first bolus 20 ml per kilo, and then we give the second dose bolus simultaneously. So the overall of the first group received the fluid up to 40 ml per kilo. That is good. So keep in mind, do not give lower than 40 ml per kilo on the first hour, right? And the second and the third group got 70 ml per kilo on the first hour. And you will see the first group received the vasoactive drug earlier than the second and third group, and they usually has a shorter duration for shock reversal. So the earlier vasoactive drug given to the patient, the better outcome, the shorter duration of shock reversal of the patients. And so on, the pulmonary edema less in the first group, and mechanical ventilator requirement is less than in the first group, and so on. The PQ stay, length of stay is shortest in the first group. So the latest study told us that the early that you give the vasoactive medication to our patient, the better outcome of the patient would be. So the time is running out, so I go quickly about this. This slide is about our patient is different from adult septic shock. you will see our patient mostly has a low cardiac index and some has a low SVR, but most of us need inotropic to augment the LVEF, to augment the cardiac output. So adult is not like a kid, and a kid is not a small adult. And I have a few minutes to go. The previous guideline, we usually divided pediatric shock to warm and cold shock, and the study show whoever you are, no matter that whoever you may be resident, fellow, or even PQ attending staff, you can rely on physical exam to predict the SVR and cardiac index on our pediatric septic shock patient. So the latest guideline told us that we should not divide it to the cold and the warm shock anymore. You should use the dynamic variable that is measured from the device such as echocardiogram or ASCOM to determine the cardiovascular parameter of our patient. So if we cannot perform the echo, we can use the epidemiologic data. We can divide the septic shock patient to the two groups. The first one is the community-acquired septic shock, and the latter is the hospital-acquired septic shock. If we see in the first group, the community-acquired pediatric septic shock usually differ from adult septic shock. They usually has a high SVR but low cardiac index. So if we see the patient at the ER and they came from the community-acquired septic shock, they usually need the medication that augment LV ejection fraction rather than vasopressor. And if we look about the axis of the vasoactive drug, you see, if we want the agent that augment the LVEF or augment the myocardium contractility, we might need a low dose epinephrine rather than high dose epinephrine or even the non-epinephrine. So I will leave with the take-home message about vasoactive drug management in pediatric septic shock. The first is the time. You should give the early as possible, usually after the bolus dose or after 20 ml per kilo in fluid resuscitation. And dopamine is inferior compared to epinephrine or non-epinephrine and do not use in pediatric septic shock anymore. Epinephrine might be initial vasoactive drug of choice, particularly in the community-acquired pediatric septic shock. And non-epinephrine can be used as alternative option, particularly in the warm shock or the low SVR state, or the patient with the catheter-related septic shock or nosocomial infection septic shock. Unlike adult septic shock, most common in the community-acquired pediatric septic shock has low cardiac index but already has high SVR and might need low-dose epinephrine rather than non-epinephrine. Thank you.